So in terms of taking a case history, doing an interview with individuals who have cognitive impairments, uh, we always want to start, if we have the option of doing a thorough review of the medical chart, and with dementia, TBI, there are different issues that we look for in the medical chart. So, for example, with dementia, of course, we would like to have an idea of what kind of dementia it is, and that's not a diagnosis that we'll make. That's a diagnosis that is going to come from an MD. And different dementias are known to have a different constellation of cognitive impairments. We may want to get an idea for whether it's the early onset of the dementia or later, how fast the dementia has been progressing. We might be able to tell that from the notes. Of course, that's going to factor into eventually us making a prognosis or even determining what to do intervention-wise. With TBI, finding out or trying to get an idea for if there is any focal damage, whether this person has issues like PTSD, sleep disorders, some chronic pain issues, things that I believe I've mentioned in some of the previous lectures. We have to remember that in some ways our observations of patients are just as valuable or more valuable, or you could argue in some ways more valuable or valuable in a different way than formal testing, simply because by its very nature sometimes formal testing is a very controlled environment, and that control, whether it's being quiet, giving patients instructions, preparing them for the fact that they're going to have to begin to engage in a task. All of these are different kinds of subtle supports for people. And so, again, people can do better on testing than they do in the real world, in which case probably their complaints or the complaints of caregivers won't match what we're seeing on testing. Or sometimes vice versa. And that might be the case where there's a little bit of denial on the part of the caregiver, a lack of awareness, or deficit awareness on the part of the patient. So the purpose of a screening instrument is to identify whether or not the individual has a cognitive impairment and whether further testing is needed. The most common cognitive screening that you'll probably see in a medical setting is the Mini-Mental State Exam. Most people just say the MMSE. That, I believe, is changing a little bit, and that's because I don't remember the year. It was approximately 5 years ago when I was in the VA. A work group started in our hospital to find a different screening instrument to use because some company had bought the rights to the MMSE, and now they were charging for the protocols and threatening to enforce copyright issues if hospitals were doing what they had been doing for quite a while, which was just simply photocopying the MMSE, the one-page protocol. But I think still you'll probably see you do see a lot of the MMSE being given out there. The MMSE is not great for people with aphasia or motor speech disorders because so many of the responses are verbal. So many of the responses required by the patient. It's also a blunt instrument in the sense that for our right hemisphere damage patients or our traumatic brain injury patients who, let's say, their problems are predominantly with these high-level communication skills that we've been talking about, the MMSE isn't going to detect that. I list here on the notes the different cutoff scores. I worked in a hospital or in a clinic where 23 was kind of determined to be the number wherein you had a problem if you scored beneath that. You can see a picture here of the different domains that are tested, and very simply how they're tested. The MMSE takes 10 or 15 minutes to give. I also worked in a facility where we gave the MMSE with all of our swallowing evaluations, when we did a bedside swallowing evaluation. And the rationale there was that we wanted to understand the cognition of these people that we were doing swallowing studies on, because of course after we were done with the studies, we were often giving them in suggestions and directions and explaining our recommendations to them. And of course, if they had cognitive difficulties, we needed to factor that in to how we educated them or who we educated. Besides the MMSE, what you'll find in a lot of speech pathology clinics, I think it's a fairly popular instrument, is the cognitive linguistic quick test, which I do believe, if memory serves me right, was also standardized on a group of individuals with aphasia, and so it's an aphasia-friendly cognitive screening. It's appropriate for other populations, TBI, dementia, etc. And you can see here in the diagram below that you get kind of domain scores from the CLQT, an attention score, a memory score, an executive function score, and a language score. You also get a general cognitive score. And the diagram goes on to kind of just give you an idea of, in a real simple way, of the kind of process you might go through in giving the screening and then deciding which test to give to kind of understand more about a problem the patient may have in this domain. And the batteries that I listed there are, I think, some of the most common ones, except the comprehensive aphasia test, which I'm partial to. Probably the more common one is the Western Aphasia Battery. The CLQT does include a clock drawing task also, but some facilities will use a clock drawing task as the screening tool, and it's been shown to be somewhat sensitive to picking up particularly dementia. You can, the clock drawing task assesses visuospatial skills, so obviously if you have a left neglect, a person is only going to put the numbers on the right side of the clock face. It assesses constructional skills, so people with those problems, their numbers are not going to be neatly along the edges, the center of the clock, where the hand faces, where the hands of the clock emerge from, is going to be way off center, etc. Planning skills, because if you think about if you were asked to draw a clock face, you would probably draw a nice circle, put the 12 at the top, the 6 at the bottom, the 3, and then a 9, and then you would go in an ordered fashion to fill in the rest so that you knew that you had a nice symmetrical clock. And so we can see people who don't have that strategy. They just start at 12, 1, 2, 3, and then they find that everything's screwed up by the time they get to 7. Below here are some videos. The first one is a person with a right hemisphere parietal stroke. So you can see what happens when there's left neglect. And the last one There was no report in YouTube on the type of problem this person had, but I'm just going to guess from listening to the interaction and looking at the drawing and how really impaired the drawing is and how much difficulty the person is having following directions, that there may be a dementia. Finally, it's again not uncommon for speech pathology clinics to have their own screening instruments. I recently, I've been helping a former student of mine who's just starting to work as a CFY in a nursing, not a nursing home, a rehab facility, doing a little bit of mentoring. And she sent me a copy of their test protocol. And they use the same protocol for individuals with aphasia, TBI, and dementia. And so it was 2 pages long, and it was really just a few brief, very brief kind of subtests. I don't know where they got the subtests from. I could guess in language, different areas of cognition. And so that's really a screening test, and probably takes less time to give that test than it does something like the CLQT, which can take 30 to 45 minutes. We need to understand our screening instruments. We need to understand them so we don't misinterpret the results.